I have no conflict of interest or relationship to disclose. Let's just go about this just step by step to make it easy. Are patients with carotid disease likely to have coronary disease? You know the answer to that is yes. Are patients with coronary disease likely to have carotid disease? Again, very high frequency of that. Are patients undergoing cardiac surgery increased risk for stroke? Absolutely, anywhere between 1% and 9% or higher. But most of that risk is not related to the carotid disease. And as a matter of fact, it only accounts for a relatively small proportion of that. And if you look overall, things like the quality of the aorta, of the use of alpha adrenergics, lots of other things play a much higher role along the way. Are there interventions for carotid disease that can reduce the risk of stroke? Well, obviously, we all know about the NASCET trial. We know that even under the highest, most stringent requirements, you still have to operate on 6 people to prevent 1 stroke within 2 years. Most people don't get a benefit. And in fact, in the 50 to 70% subset, you have to operate on over 100 women to prevent 1 stroke at 5 years. Clearly, even for asymptomatic individuals, there is some benefit, although again, you have to do an awful lot of operations along the way. And women, again, don't tend to benefit nearly as much as men do for various reasons. And the most recent version of this European study also again showed you have to operate on quite a few people to prevent 1 stroke. And there is a reduced benefit for women if you don't choose to ignore the 30-day perioperative period that the authors chose. The big question, of course, does treating the carotid disease in patients undergoing cardiac surgery reduce the perioperative risk of stroke? And those are the things we've been talking about. I'm going to take the argument that go ahead and do the coronary bypass operation, use best medical therapy, and then once everything is settled, you can address the carotid disease. Well, a lot has been said. There's been a number of meta-analysis. This is what you do when you really don't have a good prospective randomized trial. And you can see that some would argue, at least early on, that if you do the carotid first, you have a higher risk of death and MI, a lower risk of stroke. You do the coronary first, you have a higher risk of stroke, a lower risk of death or MI. If, however, you only look at those reports in which they have contemporaneous data, that is, that the 2 types of approaches that were taken about the same time, it suggested that doing the carotid first reduces the risk of stroke and reduces the risk of death. If you further require that there be at least 50 patients in each group among those, it is still a little bit more difficult, but in general, doing the carotid first may reduce the risk of stroke and may reduce the risk of death. There's only, to my knowledge, 1 prospective randomized study done, and this was from the Cleveland Clinic from a couple decades ago, buried in the middle of a larger trial, and they actually looked at sort of the reverse approach, doing the coronary bypass first and then the carotid, and so they actually thought very strongly that doing combined operation was much better. And they had a 14% combined stroke rate between the 2 procedures, which I think is outrageous. Why is that? Well, because most of those strokes were minor strokes, and in fact their mortality was much higher. The poor man's prospective randomized study is, of course, propensity analysis, and there have been a number of those. And what we learned from that addition of carotid endarterectomy CABG does not increase the perioperative risk of stroke, but it doesn't decrease the operative risk either. Our own propensity analysis at our institution showed the same thing. May not increase the perioperative risk of stroke, but it clearly does not decrease that risk of stroke. And in fact, one final propensity analysis, also interestingly from the Cleveland Clinic, suggested that it does not increase the perioperative risk of stroke, but it does increase the overall perioperative risk. Well, what if there are less invasive ways of treating carotid disease? Well, we've seen that before, the much-touted SAPPHIRE trial, which suggested that in patients, the combined endpoint was lower with carotid angioplasty. And in fact, most of that came in asymptomatic patients, but goodness, look at that, close to a 10% incidence combined outcome of stroke, MI, or death in asymptomatic patients treated with this. If you look at this, early reports suggest, well, there may be some benefit doing it, but in fact, Guzman's suggested that the combined death and major stroke rate was close to 10%, maybe close to 8% with a slightly later look at that. But again, I would not necessarily suggest that this is actually an awful lot better way to approach things. Aren't there other ways to reduce the risk of stroke? Absolutely. Best medical therapy. Dr. Robinson already talked to us about that. And in fact, if you overall look at the number needed to treat, along the way. You can see with using Plavix, using ACE inhibitors, using simvastatin, that although these numbers are higher, it's with a much lower intervention. And if you compare for therapy for asymptomatic disease, an annual risk reduction of between 0.5%, you can see that this is not that terribly far off with best medical therapy alone. This approach has been reported before, showing an odds reduction of more than 75%, using statins during coronary bypass. And actually, a meta-analysis of 19 contemporaneous reports suggests that there is a significant risk or a reduction in the risk of stroke and death with use of statins. Dr. Robinson addressed this issue. Can't we save money from doing both at worse? Well, of course, for the surgeon, it doesn't make a difference. The payment's the same. But if you look at what we actually get paid for various operations, there is no extra DRG, no extra money at all, and the hospital does lose money because you just don't get paid as much for doing this thing. Well, what does all this mean? Well, Naylor was good enough to put all this stuff together. Again, unfortunately, these are series. These are not controlled series. But if you look overall, the combined stroke MI death rate for doing the carotid first, for doing the carotid and coronary together, doing an angioplasty first, all hovers around 10%. The exception to that, of course, is doing the off cabbage a little bit. It's maybe a little bit less if you do the coronary bypass first and then the carotid. This number is actually accumulated from 12 uncontrolled studies, the majority of which were asymptomatic. So that's something we do have to pay attention to. Jay, I've got a little bit updated slide here to show you. I went a little bit extra effort. But you'll see that, in fact, our stroke rate with our coronary bypass surgeons has clearly fallen over time. But I would point out that overall, the prevalence of combined operation has not changed. Most of this reduction is probably because of the use of off-punt cabbage being done, as well as the use of concomitant medical therapy. Looking at it over, the addition of carotid endarterectomy may not significantly increase the risk of stroke to coronary bypass, but clearly the addition of coronary bypass to carotid endarterectomy clearly increases the risk of that along the way. So I'm going to give you, I don't have enough time to give you the top 10 reasons, I'll just give you 6. First of all, I would submit that there is absolutely no compelling evidence that perioperative stroke rate is less with combined surgery. The hospital loses money. It interferes with your operative schedule, no doubt about it. The exposure is difficult because you can't turn the neck as much because they've got all those other drapes on there. The scrub nurse doesn't know your routine because they're used to dealing with the cardiac surgeons who use the wrong instruments anyway. And finally, if the patient has a stroke, you get blamed for it. I think that's why our cardiac surgeons like to do it. Well, can't we all just get along? Probably so. Let's compromise. I think that there are indications for doing a staged procedure, doing the carotid first in situations where the patient has stable cardiac disease and they clearly have severe carotid disease. Doing them combined with unstable carotid disease, unstable cardiac disease, alternative stage, pretty much for the same thing, but only if you don't know how to operate on the carotid. Perhaps off cabbage would be best. But in any event, I would offer to you that coronary bypass surgery and best medical therapy for carotid disease ought to be used for people, men with lesser degrees of stenosis or women with any degree of stenosis because the benefit for women is much less. And then finally, consider carotid endarterectomy once they're out of the perioperative period. Thank you very much.